No, you are not audible. You are not audible, sir. Even sharing is also stopped. We cannot hear you. Yes, you are audible, but not the.
Audio not clear. Not clear.
I'll give one. Left hand. Uh, yeah. Yeah.
Not clear.
Meeting.
Cannot hear at all. Voice is very bad.
At 6 months of age, he had another episode of paroxysmal event of same simiology, during which he was started on syrup levera and syrup gardnerol dose was increased. And later on, in view of no repeat episode of convulsion, both the medications were stopped at the age of 1 year. The developmental history The developmental history of the child is as follows. Gross motor, he has achieved head holding at 4 months, rollover at 6 months, sitting with support at 7 months, sitting without support at 9 months, and standing with support at 18 months, and walking with support at 2 years. The child has never achieved walking without support. Fine motor, the child reaches out for object at 5 months, mouthing was present at 6 months, transfers object at 10 months, scribbles at 15 to 16 months, and self-feeding at 1.5 to 2 years. Language-wise, cooing was present at 3 months, monosyllables at 6 to 7 months, blabbles at 8 months, bisyllables at 1 year. Social, the child could recognize mother at 4 months, waves bye-bye at 10 months, and comes when called at 1 year. The child can fix and follow and turns the head towards sound or voice. Bladder and bowel control was never achieved. There is no history of tightening of limbs or difficulty in changing diapers or fisting or arching or any involuntary movements. In between the age of 1.5 to 3 years, the parents noticed that the child was slower as compared to the other children of the same age and had not achieved the same milestones as the elder sibling had for that age, but they did not seek any medical help for the same. At 3 years, the parents noticed that the child started having difficulty in standing with support, which progressed to being able to sit only when made to sit. Gradually, he could sit only with support, which progressed to inability to get up from the bed, and now he has lost head control as well. He also couldn't feed self and had difficulty reaching out for objects, which progressed and currently is unable to hold an object when placed in his hand, but can elevate his hand above the level of the bed. He cannot move his leg above the plane of the bed. He can recognize mother and father. Cooing and laughing out loud is present. He can respond to name and interact with his siblings. Fixing and following is present with turning his head towards the source of sound. The impression was global developmental delay with regression of the milestones with a DQ of 3%. The mother also gives history of looseness of the child noticed by her since 3 years of age. And there's history of prolonged feeding time present. There's no history of any exaggerated startle, no history of any cranial nerve involvement, no history of any seizure in last 1 year, no family history of any seizure, no history of any ulcers or bed sores. 6 months ago, the child was brought to Mumbai for treatment and shown to a private practitioner in Thane, where he was worked up. EEG was done, which was told to be normal. Blood investigations were sent. MRI was done, and whole exome sequencing was sent. All the reports were conveyed to the parents, and the child was told to have some brain abnormality, which had caused the regression of the milestones. They were counseled regarding the progressive nature of the disease and the grave outcome. He was also admitted 4 months ago at Vadia Hospital for 8 days in view of lower respiratory tract infection. Some injectables were given, oxygen requirement was present, nebulization was also given, and was advised physiotherapy. Currently, the child has been admitted for lower respiratory tract infection, started on some injectables with no oxygen support required. He also had one episode of paroxysmal event in the ward of the same simiology as before, lasting for a few seconds, and was started on anti-epileptic drug. Immunization history, the child is immunized till 1.5 years of age. Dietary history, he was exclusively breastfed till 8 months, then started on complementary feeding with dal water, and breastfeeding was continued till 3 years. He used to consume 4 out of 7 food groups. Feeding time was prolonged since each bite containing small pieces was kept in the mouth for prolonged duration, followed by swallowing with minimal chewing. The family belongs to lower socioeconomic class as per modified Kupuswamy scale. The father is 32-year-old, mother is 29-year-old. The patient has an elder sibling, 7-year-old girl child, and he is 4-month-old.
Can you hear us, Anjali?
Yes, Rajesh.
Okay. We'll go to the second step. So obviously this fever 4 days ago and cough and all seems to be a trivial illness. So maybe we'll skip that and we'll come to the main past history. Sir. Just to try some different ways. Forget the past history. Imagine this is the first history. Can you guess that this child must be not a normal child? How can you guess that? You get my question? Okay. Means you should start thinking right from that first sentence. So why did you say that you anticipated an abnormal child? It could be normal child, no? So what made you say that? Give a thought. So now I'll guide you that a 4-year-old child, right? How often you have seen a 4-year-old child coming with some fever cough and within a day starts getting breathless? That happens typically in an acute bronchiolitis, which happens often without cough or with a minimal cough. It happens in an infant, not at 4 years. So what kind of respiratory infection is that?
Lower respiratory tract infection.
Why should a child 4-year-old get lower respiratory tract infection, and why lower respiratory tract infection gets breathless within a day? You get the point? Give a thought to all that. And the point that I'm making is, if you just look at that, then of course you want to know how severe was the cough. The cough, if severe the cough, less is the chance of fever and also less is the chance of breathlessness. Not that these are not the statements that can hold true everywhere. But a bronchiolitis who gets breathless very early has hardly any cough. A pneumonia who gets breathless within a day or two has minimal cough. But if the cough is severe, the complications are less likely, chronicity may be there. So you start looking at all that and you straight away say that this child is not a normal child. Now, if you say it's an abnormal child, what kind of abnormality? CF, cystic fibrosis, ciliary dyskinesia, severe malnutrition, common causes of a severe infection. Why not? Why not a malnourished child with infection? Again, the pneumonia would not have just come up in one day's time with breathless, but breastfed till 8 months of age, unlikely to be severely malnourished, though it could be inadequate milk. But therefore, all that history would have been important. So suppose we come to a conclusion that this child had reasonably good health, may not be fully normal, but fair. So malnutrition is not the cause. Then we may want to say genetically determined disorders like CF, at which time ask for the stools, ask for the family history. If that is not there, then the other cause is the delayed development. The point I'm making is I'm not anticipating delayed development, but I'm anticipating some abnormality. So I think that is the way.
Can one think of a cardiac disease? This child, we don't know the past, but he has had some fever for a day, and second, third day he became breathless. Maybe there was a history of recurrent breathlessness, etc. At this time, we don't. But something wrong, definitely, as Sir said. It could be cardiac, and this particular child's breathlessness was more attributable to the cardiac disease, or was it an aspiration? A 4-year-old child is not likely to aspirate very easily unless he has a neuromuscular swallowing defect. And respiratory problem, most unlikely to be present either pulmonary disease or airway disease. So it is primary lung disease, perhaps not. If there's a lung disease, it is because of a sudden phenomenon like accidental swallowing or regurgitation and aspiration, or could be cardiac, or could be something which we normally don't think of, and wherein the child breathless is muscular. That means his respiratory muscles are not able to take that sign. So he could be tachypneic because of respiratory muscles are weak, and therefore with trivial sickness he became breathless, or he could have an underlying cardiac disease, or maybe suddenly aspiration, which is perhaps the least likely. But certainly, as sir said, 1 day of fever and third day he becomes breathless without any significant thing. Our antennas are up, is all is not well. And even one sentence added later on, that is physical development has gone down, tells you that it is neither cardiac nor swallowing, but it must be most probably respiratory muscles which have gone wrong. There may be some muscular abnormality. And then we will think of whether is the gross development got wrong, or the gross and sensory and sorry, social also has gone, cognitive has gone. With the global development or no? And even in global development, is it the gross motor which is most affected and other things are most? So this is what, so I thought up to before we knew that, I thought whether it was cardiac. And the second thing that came to my mind was respiratory, but cardiac came to my mind first because we don't see so much of respiratory weakness of muscle origin giving rise to breathlessness.
But here was the deep respiration, right? Not a respiratory problem, not a cardiorespiratory problem. So this is a renal problem, acidosis, deep and rapid respiration. Again, must be malnourished child. Okay, chronic renal tubular disorder. What is your take on that? Acidosis, deep and rapid. Common cause of metabolic acidosis at that age is RTA. RTA is usually malnourished. So straight away you get acidosis of metabolic acidosis, not respiratory.
One clue.
Such children don't have cough.
Yes. Acidosis with cough and acidosis without cough. Who gets cough with metabolic cause?
So now start discussing the global developmental unit. Come on, who will discuss, put the next slide and discuss the global developmental delay. Come on, one of you now. Thereafter, she will also come down on that. Oh, just prior to that, I'm sorry, I distract you straight away. Prior to that was a seizure, right?
Yeah.
So just put that. So on day life 40, child had seizure. But till then, child was all right. Why is that? Breastfed baby, okay, doing well in the first 40 days. Then why should that child have a seizure? Any thought? Go on talking. Okay, unless you talk, you will not improve. Start thinking.
Can it be hypoglycemia? Suddenly he had some seizure and got better. 40 days, small child, hypoglycemia? Possible? Who gets hypoglycemia on day of life 40? Day life by 4 is okay. Day life 40 where everything is established very well, feeding is established every day. So unless there is some additional metabolic problem, hypoglycemia is not like. So that's out. Anything else? Yes.
A normal baby up to 40 days has no business to have a seizure. So there's no acquired cause. So there has to be an inborn cause. What inborn cause? Inborn error of metabolism? The seizure would not have just ended up that way, but the child would have got unconscious, vomiting, etc. So it's not an IM.
And
It's not,
also probably day 40 of life was little too late for indoor errors of metabolism.
I mean, IM may depend on degree, IM may present at any age. But seizure is not the only presentation. Seizure, unconsciousness, vomiting. Okay, this child had a seizure and seizure was self-aborted. So it is not an acquired or congenital or hereditary IEM. It's not infection. So again, surely it has been a subtle brain damage. And what subtle brain damage? History is not suggestive. But just because the baby cried at birth, you're not sure whether there is a brain damage or not. So how would you pick up a possible birth injury at this age? Parents have said everything is all right. And at 40 days, he was all right. We anticipate this child was not all right. Okay? What? So in other words, how do you make sure that birth history was normal? The parents cried immediately, started breastfeeding, discharged. Okay, that doesn't mean there's no brain injury. So my question other way around is, have you seen a baby just being born? How does a newborn who is being born behave? How do you behave at birth in a normal situation? If that is not happening, there is something to describe the behavior of a baby at birth. I'm sure you all have seen babies. As a pediatrician, you can't say, no, I have not seen. Even an adult must have seen. So how is the behavior of a newborn at birth?
The baby will wake up for cries for feeding, and if fed adequately, the baby will sleep for an adequate amount of time, and overall there won't be continuous irritability.
Okay, soon after birth, the baby will be sleeping or will be alert?
Soon after
Alert for some time, at least half an hour.
Every normal baby at birth without any brain injury cries, looks active, crawls to the breast crawl, UNICEF video, right? Sucks vigorously, remains awake for 20 to 30 minutes, thereafter goes to sleep, sleeps for 3-4 hours, and thereafter starts sleep and wake cycle and feed cycle. He's a normal baby at birth. Just because he cried and just sucked at the breast doesn't mean anything at all. Cried but never stopped crying. Abnormal. Did not cry, may not be abnormal, rarely, but the rest of the story. Okay. Cried but was not active, did not reach the breast, was not trying to suck, abnormal. Sucked for just half a minute and went to sleep, not normal. Slept for 4 hours, did not wake up, not normal. How important all this. So henceforth, birth history has to be asking all these details. Most of the mothers won't know all this. Okay, doesn't matter, but you need to ask all that. This baby must have gone through that kind of abnormality. Then why did it not manifest in the first 40 days? Why did it not start first 40 days? No. First 40 days. In other words, the injury may not have been that severe, but right? Yeah. Come, let's take it further. The development phase.
And there were further seizures at 3 months, 6 months, etc., right?
So total about 3 or 4 seizures. Yeah. And now the developmental history. So someone interpret this developmental history.
So in gross motor, till sitting till rolling over the milestones were achieved appropriately at age, then 1 month delay has been seen. Sitting with support should be at sitting with support is 6 months, which has come at 7, without support at 8 months. After that, the delay has been significant. Like standing with support should have been at uh, l- 10, 11 months, and walking with support should have been by 1 year, which is now at 2 years. So from
Okay, so when you say sitting with support at 7 months is delayed, first of all, when you say sitting with support, what do we mean by that? So in other words, I want you to tell me how does sitting, how does a child sit first, then how does the child progress, and then finally, how does the child sit without support?
there is this tripod position first.
So that is known as, so first is forward propping, then is lateral propping, and then independent. So therefore, the first support is forward, that baby is all jhuka hua like this, but taking some support there, right? So when we ask for support, we have to ask for that. So this whole thing is 6 to 8 months. So even 7 months, you can't really say that it is delayed or not. We are not sure. Okay. Now, what is the importance of this lateral propping? In one condition, it is important. What is that? Very good. So in hemiplegia, what will happen?
We cannot make out if one side is weak, the affected side he will not do propping. The intact side will do the lateral propping.
So if he doesn't do propping on right side, left side, let's say, what will happen? He won't sit. So sitting will be delayed. So when you have delayed sitting, so typically if you have a, means head holding normal, fronto supine normal, but after that sitting delayed, then you suspect a congenital hemiplegia, whether he is not been able to prop laterally. So that's a small clue. So till that time we are okay, and then standing with support at 18 and then walking at 2 years. So this is the delay.
How does the child get into the sitting position? Child is crawling at 6, 7 months, let us say, but how does it get into the sitting position at 6 months?
We'll first learn rollover and then sit with support.
But first we'll roll over, go to prone position. From prone position, is he able to get into the sitting position? Or when made to sit, he will sit in the sitting position with lateral propping. Because coming to sitting position is acquired when the child starts crawling on his knees, then he crawls on his knees and comes to the sitting position and crawls on his knees and comes. So when made to sit at 6 months, then he will sit with support, forward cropping, then lateral cropping. And okay. Also wanted to tell that giving 23% is not right. Well, you should have been in the beginning 4 upon 4, maybe 100%, 6 upon 6, maybe 100, 7 upon 7, maybe 100, almost that. And suddenly, so this particular child's walking is delayed. So maybe or maybe not, you think whether there's anything wrong with the lower limbs, or maybe even a metabolic disease, including rickets, where other things may be normal. So you need to give the awareness.
Okay, now someone analyze the fine motor.
He's reaching for objects at 5 months, which is um, first they'll there's wide whether it's bidextrous or unidextrous reach.
Okay,
5 months would be appropriate.
okay.
Mouthing at 6 months is also appropriate for age.
Okay, so mouthing at 6 months means when should mouthing start? It should start before reaching for objects or after reaching for.
Before reaching for
Very good. So therefore, when should mouthing start?
4 months.
3 months, even 3 months. Okay. So that is mouthing. So mouthing, if this history is right, then it is delayed. Okay. See, in all these things, you have to always also be careful about how accurate is the history. See, parents are not pediatricians, so they wouldn't have made a perfect mental note of each and every milestone and age. So you'll have to judge that. Then transfer of objects at
10 delayed.
delayed. Then scribbles at 15 months. What do you think? It is appropriate. So therefore, again, now you question yourself that if scribbling at 15 months, which is at a later age, is appropriate, then the earlier age milestone, is it really delayed or is there some mistake in the remembering or in the history or whatever? Okay, fine. Then language. So tell me about language.
Cooing was achieved at 3 months, which is appropriate. Monosyllable at 6 to 7 months. Again, that is also appropriate.
So what is monosyllables?
Like a single word thing.
Da, da, ba, ba.
da.
Okay. Then
Then blabbles at 8 months, which is also appropriate. And bisyllables was at 1 year, which was mama, baba. He could say it like around 1 year of age. So that was comparatively delayed. And
slightly delayed. Okay.
And after that, he's not achieved any other words, like no word with meaning other than that he could say.
Okay. So now this mama, dada, is it meaningful words or they are not meaningful words? Correct. So when you are taking a history and when you are saying that monosyllables at 7 to 8 months, which is ma, da, ba, ba, and then da, da, ba, ba, that is bisyllables. So when the baby says da, da, ba, ba as bisyllables and you say this is bisyllables positive, that time you want mama to be for mama, mama to be for anybody. Mama to be for mama. No. That bisyllable is just the joining of ma and ma to make it mama, baba, dada. It is not intended that baba is baba or dada is dada. That time it is just the joining of the two syllables. So instead of just ma, da, ba, it becomes mama, baba, dada. 1 year is the meaningful word. So that time they may actually use one of these for one person. Then it becomes a meaningful word. Okay. Social. You tell.
Social recognizes mother at 4 months, which is delayed. It must be by 2 to 3 months of age. Waves bye-bye should be by 7 to 8 months of age. And response to name also by 8 months, around 8 months.
Yeah, 8, 9 months. So, but I mean, 1 year is not bad. So, you don't know whether he was not responding at 9 months, whether he learned at 1 year only. So this almost looks normal, right? So now, based on this, what do we say? Means this may or may not be correct, but we are learning some concepts. So based on this kind of a developmental history, what is your interpretation?
In all the domains, 1 year is the cutoff, and later child is not achieving further milestone.
So, so that is mentioned. So in both social and language, there is no further achievement. Okay. Okay. Fine. So that's almost like a developmental arrest, actually, and which seems to be from this pretty fast and sudden. Though I think there must be some gaps in the history. And I think everything tells us that the story started developmentally by about 6 of age. Apparently till then, but there was seizure at 40 days. So some brain problem had started much earlier, though we could not see a definite delay in the first 4 6 months. But thereafter, the delay is not only very clear, but certainly now at this age, it is further worsening. And that tells us that is it likely to be static or a progressive disorder? What do you think it is?
Since there's worsening now, it could be a progressive disorder.
Fine. So apparently all right at birth, though we are not sure whether how all, but surely the things are deteriorating over time, and now it has gone so. So not only it's a progressive disorder, but it's a disorder where there has been a sudden blockage for further development. So that's another point. So the onset looks to be slow, but something worse than all of a sudden. What kind of that must have been? You get my question? He said that sudden stoppage of gaining milestone. So some milestones were also borderlinely abnormal earlier. So why did that happen at all? Can it happen with neurodegenerative or metabolic disorder? Or it must have been some further injury somewhere? That's my question.
It can happen with a metabolic disorder.
That's right. It can happen with metabolic disorder, but had it happened only because of, say, sudden vascular episode, it could have been ultra sudden. This was not that, but suddenly something worsened, something stopped happening further. That's typically a neurometabolic disorder.
Yeah, we thought that it could be neurometabolic disorder. Can it be a congenital malformation at their 40 days? And then can it be congenital? Because you say that the child started going down after 1 year. But he has presented in life as early as at day 40 of life with seizure. Maybe even the earlier milestones would not have been so good as they appear to be. So if there was significant CNS malformation with presented at 40 days, further gaining of milestones I thought was a little too good for that. Therefore, the milestones were achieved and now being lost.
That this, if we say it's a progressive disorder, then we go out of. Then neither it is a cerebral palsy, nor it's a congenital malformation, nor it's a chromosomal disorder. They will not go on worsening, at all they might be improving. So small difference. Give your summary. Slowly, gently, without break.
So 4-year, 4-month-old boy, second by birth order, born of third-degree consanguineous marriage, who came with the complaints of lower respiratory tract infection, with global developmental delay, with regression of milestones, with seizures, with normal antenatal and birth history, with no similar sibling history, with prolonged feeding time, is probably a case of metabolic disorder, genetic syndrome, floppy infant, or neurodegenerative disorder. So we have the patient here for examination.
Floppy infant is not a
It's not. Yes,
diagnosis.
sir. Yes, sir.
So take that away.
Yes, sir.
We'll call them. Come close fire and don't touch the baby. Just tell us what you see. We just wait for all this. Well, 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 it's not time for 4 years. Wait a minute. Next, uh, primary care. Yeah, usually, nothing. Uh, I look at the you look at now. Uh, the frontal washing is different, but head size is different. I don't think we can call this a large head. Anyway, we'll see the measurement. So will you say, what about consciousness?
Child is conscious but does not respond verbally, like is not making any sounds. Less interactive.
So less interactive, fine. So we've discussed this many times, no? Okay. When you are, suppose I ask you, is he conscious or not? How are you going to answer? So what is the definition of consciousness? That the patient is able to respond to
when
the environment. So how will you judge that? And response to environment is by voice, by vision, or by a painful stimulus. So first you say that he is awake because his eyes are open. Is he alert or he is not alert?
have to check by calling him.
So check by calling. Now when you call,
I mean, sir made noises, he called, he didn't seem to respond. So does it mean he's unconscious? It could be that he has a hearing defect.
Hearing defect.
So you choose other stimuli to check whether he reacts. Okay. So now what did I do?
Eye con
Abdul. Abdul. You have to see whether he's focusing. I think he's focused.
What is AVPU?
Alert, verbal, pain, and unconsciousness.
So in this child, he will say that he is. So alert means he is responding to everything that is happening around. So he is probably not doing that, right? So we have to check whether he is responding to voice or is responding to pain. Now this correlates to GCS at what level? A full modified GCS responsive to pain correlates at what? GCS of 8. And why is that important? 8 is for intubation. So anybody who is not responsive to voice but responsive to pain is equal to GCS 8, you might have to intubate it. Right?
That must be for an acute onset problem, not a delayed development problem.
Now, as I observed, as Dr. Rajesh was talking, he started looking up. When the mic went from him to him, he started looking up. So he's alert of what is happening. So the responses may be. He's alert.
Not just voice to affect vision also. Vision, imagine the vision also must be defective. So you need to be close face of this baby, not from a distance. When he called his name, he went very close. In fact, he also showed a gesture of understanding and smiled a little. Okay. That means, and that's what you do for a newborn or a very young infant. You have to go very close to it because it's 6 by 36, 6 by 48. So you can see how you go on. So what else when you talk in CNS cases? When you talk of head size, then you talk of dysmorphic features,
feature.
present or absent.
Ab-
third, fourth, sixth in order, he is moving it there. But once I was following.
Project, what is that? Yeah. What about other This is happening. What I think what critical possible bounty is like okay. You want to help with it, I need to send the coding right to the receiver. This one is good. But it is something that might be this is good by dying, but I moments of the next
पेशेंट ना फॉल होगा दवाई सब चलेगा ये दोनों ताकत का है 5 दिन सर्दी वाला सुबह शाम खा लेंगे नींद जैसा आएगा तो टेंशन नहीं लेना और रात के रात एक ठो गोली खाने के लिए दिए हैं 10 दिन और सुबह शाम लेकिन ब्लड प्रेशर न लेना देखो चार दो बार गड़बड़ आया उल्टा पुल्टी आ रहा है इसलिए लिखित में लिखवा लेना वो लोग ठीक से नाप से लिख देंगे ठीक है
Everybody please mute yourself. Every viewers please mute yourself.
तीन बच्ची के बुखार वाला के दो बेटा तीन बच्ची के बुखार लगे लगा बिना देख रहे हम कुछ ना बोला दवाइया बच्चा उल्टा कितना दिन का बच्चा हो 1.5 साल की बात छोटा बच्चा 1.5 साल एक चम्मच सांझे बहने सांझ सांझे सांझ एक चम्मच सांझे बहने अच्छा ठीक ठीक है छोड़ दो मेरा नंबर दिमाग में बोले ना मुझे ताकत के दवाई लिखल बा आ एगो पिए वाला दवाई बा बाकी ब्लड प्रेशर ठीक से देखा ली नाप करके अगर लड़को गड़बड़ हो ताके भेंट कर देखो 2 दिन 4 दिन देख रहा 3 दिन में ना आराम मिली ब्लड प्रेशर के बात होगी तब तो भैया से तोरा भेज दे देखा हमरा से ना पार लगे समझ गए ना ब्लड प्रेशर नपवा के 2 दिन में आके देखा
What you should do is you should hold the limb like this and now raise the knee. Hold, hold it this hand. You show the hypotonia. So is it hypotonia or spasticity? Or both?
Hypotonia along with the spasticity component.
So you have an upper motor neuron and a lower motor neuron lesion.
What? You have both, or in one, the other can be present.
Upper motor neuron region can present with spasticity as well later on stage.
Spasticity is upper motor neuron
Like
and
limit-
hypotonia is lower motor. So now decide which one it is.
What is the final pathway? Lower motor or upper motor? So if final pathway is gone, then that will dominate.
कोई है ये नहीं है बाहर में, अगर निकला तो बंद
Sorry?
करवा देना। हाँ। क्या बोल के आए थे?
So in upper motor
बोले कि
neuron
ऐसा अभी
lesions,
अजीत
there
था,
are
अजीत
many
अजीत निकल गया, तुरंत घंटी
intracerebral
बजा ही रहे हैं,
pathways
निकल गया
which
बिना
can
बताए हुए।
contribute to
1 सेकंड
hypotonia,
के अंदर गायब हो जाता है
even in
उड़न।
upper motor neuron lesions.
कोई भी
So the
वो तो
presence
अभी
of
हुए हैं,
any
मत
clear
करा।
signs of spasticity
हाँ तो जो भी
with
हो,
Please
upper
mute,
motor
Pallavi,
हाँ
please
हो तो
neuron,
mute
वहाँ पर
others.
in upper motor
जब
neuron
हो
you
तो
can
यहाँ
have
गए हो।
simultaneous hypotonia as well because of damage in
में
the
जहाँ फंसा हुआ
CNS
है, ऐसे
to
ढक्कन खोला
fibers
हुआ है,
from one area to
गायब है।
another. Okay. Ulta
Others,
cannot
please
happen.
mute
In
yourself.
lower motor neuron you can't
Pallavi.
get spasticity, but in upper motor neuron you can get hypotonia.
Do you think it's a non-neurological hypotonia? Why do you call it neurological? There is no loss of power. We haven't tested it, but apparently may not be. But suppose there is no loss of power, then it's not it's not a low motor neuron. Then could it be malnutrition? Does Downs have a hypotonia? Where is the lesion? Lower motor
बाहर
neuron,
बंद कर दीजिए।
upper motor neuron,
हाँ
and
जाएगा,
hypotonia.
देखिए उधर से उधर खुला है, कोई है नहीं।
Where is the lesion in Downs?
Central hypotonia, diffuse.
That's what Dr. Rajesh was talking about, that when multiple connections are disturbed, that means it's a widespread neurological disorder, you would get even hypotonia. So this child must have had both a widespread disorder plus also the pyramidal tract disorder, right? Just check the power.
नहीं सबको अभी म्यूट हो गया सब
Co-host बनाने के लिए I can control.
But possibly the child is not responding to your stimulus. Okay, it was not painful, it was just a tickle. So child was not responding to it. That's the level of response. But when you make to have the leg stand like this, you might find it's not dropping down completely. So for a while, so of course that could be even a spasticity doing it. So we need to be very sure, but surely it's even a tone itself can just make you flop like this. So we need to be very sure. Take a reflex. But right. Sit.
Quickly summarize your findings.
Lower motor neuron, upper motor neuron, at every level, there is evidence of increased tone. Though the infant looks quite hypotonic, on examination of tone in lower limbs as well as in upper limbs, there is a catch when we see. In extension of the elbow, I have an inspection, more in extension. This is an example where there is underlying spasticity or maybe even increased tone in the form of rigidity, though we did not get classical. But finally, the child looks hypotone.
Impression. A 4-year, 4-month-old boy who presented with lower respiratory tract infection, with global developmental delay, with regression of milestones, with myoclonic seizures, with no significant antenatal and birth history, immunized till date, with acute and chronic malnutrition, with dysmorphic facies, with hypotonia, with spasticity with preserved reflexes, with clonus, sensory system being intact, nystagmus present is a case of floppy infant, central cause to rule out metabolic disorder or genetic syndrome.
Why did you say dysmorphic features?
So because there was deep-seated eyes were present, pinched up nose I could see, along with frontal bossing, which means prominent forehead was present.
Okay, but see, frontal bossing is a very non-specific thing. So that's not a very strong dysmorphic feature. And yeah, the other thing is that floppy infant, typically the term we use when during infancy the complaint is of being very loose, or you see the infant as being very loose. This is now a 4-year-old boy. So we shouldn't use the term floppy infant for him, right? So that's the second thing.
Investigations. CBC was done, which was suggestive of HB of 13. Counts were 9,100. Platelet were 3,20,000. Hematocrit of 37.9. MCV was 82.9. MCH was 28.4. And MCHC was 34.2. LFT, the total belief was 0.4. SGOT and SGPT was 45 and 20. Total protein and albumin was 8 and 4.6. BUN was 7 and creatinine was 0.4. Sodium was 135, potassium was 4, chloride was 101, and calcium was 9.2.
Proteins are very high. So what is the cause of that? We always talk about low protein, right? There is high protein. Look at albumin 4.6. It's higher. So there is a hyperproteinemia.
So can you talk of any situation where proteins are increased? What is the other protein besides albumin?
Globulin.
And when does globulin increase?
Inflammatory states. Sorry.
Inflammatory or autoimmune,
Autoimmune.
right?
In other words, when the protein levels are high, if the globulins are high, then it's likely gamma globulin could be high commonly. Alpha 2 can be also high, but then total proteins are low and albumin is low in nephrotic syndrome. And therefore, here if you look at it, the globulins are reasonably good. They are not increased. So to that extent, you would have said, this is just normal and leave aside. I just wanted you to get into that discussion that high proteins are always high gamma globulins. And here globulin is 3 point something, which is fine, right? So this is not abnormal.
MRI brain report was suggestive of bilateral symmetrical abnormal signal intensity involving the dentate nuclei and peridentate white matter appearing hyperintense on FLAIR images. Similar increased signal is also noted in ventral medulla along the pyramids with subtle increased signal intensity involving the transverse pontine fibers in the central pons and mild increased signal intensity involving the posterior periventricular white matter and centrum semiovale. Findings are most likely suggestive of congenital or hereditary disorder. The genetic report of the patient was suggestive of homozygous variant of peroxisomal acyl-CoA oxidase deficiency, autosomal recessive, which was likely pathogenic, and also malonyl-CoA decarboxylase deficiency, which was autosomal recessive of uncertain significance. Thank you.
So incidentally, on these genetic reports, what is this uncertain significance? What should you or we as a clinician infer from that?
We cannot consider that to be the pathology. We need to look for other causes still.
Okay, so one is that you cannot consider that to be the pathology. Why? So why are they calling it uncertain significance?
Less cases have been reported, less cases with similar presentation and genetic correlation have been reported so far. So we can't definitely pinpoint it, attribute it to the genetic cause. But if reporting case report increases, they can convert it to of pathological significance.
So in other words, how does genetics library works, that every such case the clinical findings are stored and whatever gene was isolated is stored. So once for a particular gene, there are X number of cases which all have a similar clinical findings, then that gene will move from variant of uncertain significance to likely pathogenic, right? So this data collection and library is important, and every means all over the world there are different libraries. So everybody keeps feeding on in those libraries, and eventually these things move from one section to another, right? Shall we have another case? How will you counsel? This is the other child, second child. Okay. They can go home. I mean, go to the ward. You'll have to go. Chal, Amrut, how will you counsel?
First, we'll ask the parents what they have understood till now. And after that, I'll introduce myself that I'm Dr. Amrita, and I'll tell that the child has got inherited disorder, which which can which is not of their fault, but because of the disease, the child is having these manifestation. And then for like further prognosis and management, if I can tell that I will have to further study and then tell, or if the grave prognosis is there, then we can tell them that
So regarding the prognosis, we aren't entirely sure up to what capabilities the child can, but like it seems we like we should continue. We should put in efforts with physiotherapy and to prevent further spasticity, or to prevent further complications. We can try uh, therapy and physiotherapy to improve the capabilities to which the child can function.
yeah, also tell regarding the AEDs, since the child had convulsions twice, and also he has got respiratory infection and current infection we can treat, and also further infections we can be prevented by hygiene and immunization.
I think when you do counseling, two things are important. You give the right information, but not making the parents unduly worried about it. Okay. And don't give a prognosis. Okay. So, what is this disease? Your baby has had some problems with the brain. Okay. And several parts of the brain are not working well. Therefore, the understanding has not been normal. The ability to stand, walk, etc., has not been normal. Okay. And on examination, we also find that there are correlated findings which tells us that brain is damaged at multiple places. This is the disease. Then why did it happen? That's the next thing. As this happened first time with a convulsion at day 40, it appears that baby has had a problem very early in life, maybe even before birth. And nothing specifically happened after birth. So likely this baby is born with this defect. Okay, that's the origin of defect. What kind of defect it is? It could be a manufacturing defect, which means there is a defect in the material of the brain, or it could be some problem with a nutrition supplied to the brain, and that is your metabolic disorder. So we explain them to that whatever you eat, it becomes an energy, and energy is supplied to every part of the body, including the brain. If whatever you eat or drink, if a product of energy development is not normal, then it becomes a poisonous product, and that damages the brain. So we tried to investigate whether this child has been born with a defect which is like a manufacturing defect, or whether this is to do something with what the food is not preparing energy in a right way, and there is some poisonous outcome of that energy production. That's why this. So explain to them that in an industry, when the gases are let out, they could be poisonous. Okay. So when we investigated, it looks like that it's a manufacturing defect. Then the question is, why did we not make out before birth? Why did we not make out early? Because this defect is not seen as an abnormality in a structure, but it is seen as abnormality in function. But today's advances, an MRI has shown even the structural defects, which we can't see clinically. That's why we did an MRI. So now they have understood what the disease is, when did it start, why it has started. Now the question is, why did it happen? In our family, there is nothing wrong. So to which the answer is, if your forefathers, earlier generations have had something of that kind, in between the parents are apparently normal, the other child is normal, but still it could be genetic, or sometimes the genetic disorders may not be passing on from each generation to another, and that is sporadic genetic abnormality. So this is what is genetic is. Whose fault it is? Nobody's fault. It's just a destiny. So don't blame anybody. Okay. What will happen to it? Now what will happen is, whatever the brain is damaged, we may not be able to undo the damage, but we can make the damaged brain work to some extent. Okay. And that's why therapy, physiotherapy, speech therapy, whatever. Okay. Now, what do you expect? This child will walk, this child will go to school. That's a question. To which you say that we will plan therapy for the next 3 months, when we try to stimulate the brain, we try to do physiotherapy, okay, occupational therapy. So all kinds of therapies, look after nutrition well, and once we do that for the next 3 to 6 months, you come back for a follow-up, at which time I will know how much improvement is seen. And based on that, I could possibly tell you how long it may take. Now they're happy, they're satisfied that you have to see how much is improvement. Though in my mind, improvement is unlikely. But you don't have to spell that. You have to say, come back after 3 months, and then only I know the response. So when you teach a child as a tuition teacher, I'll say, what's the prognosis? Now let's have 1 or 2 examinations. Let's see the result. Then we will know how much more we have to do for a final exam, right? So they say, yeah, that is right. A teacher can't tell you prognosis when he starts teaching. So that means what have we done? We have told the truth. We have not told them the complete truth that we possibly know. But in medicine, we might feel the prognosis bad, but he might start improving as well. So keep that hope in mind. And most important, keep that hope in the minds of patients so that they will do their best. After 3 months, when they come, they also find there is no change at all. You also know there is no change at all. So you say sometimes the improvement takes longer. So we will do the same for another 3 months, and let's see what happens. Very soon, they will know there is no need to come to a doctor. There is no improvement at all. You don't have to give them a shock. I remember first Down syndrome that I saw in early 70s. The parents came and said, I said, what is wrong? He said, you only see. No, I said, what have you come for? No, 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 just see it. Now, obviously, it was a Down syndrome. Okay. They did not want to tell me that he is a bit delayed. Okay. They say, Api dekho. So when I saw Downs, I explained them. And they said, what's the treatment? I said, look, we can do many things. So they said, many things. Two doctors whom we have met, they said, there is no treatment. There is no treatment is not right. Treatment is not drugs. Treatment is not what you get at the chemist. So when I told them that, oh, he will go to school also. Okay, how much will study? He said that even you don't know normal child whether he becomes a MD pediatrics or DNB or fail or what. But he will go to school. I remember that child. That was a Bengali child. The parents were to go to Bengal. They informed me a year later to say they have got Down Parents Association that they have started because they said doctors told us there is no treatment. No treatment is right, but no drug treatment. So even for this, there is a treatment. Okay. So that is counseling, right? Who is presenting?
A word about uh, next child. Autosomal recessive, probably third degree consanguinity. They have one healthy child. Would you like to talk a word about the next baby? Perhaps I would. One baby is normal. We never know what will happen to the next baby. Autosomal recessive, almost certain, and 25% chances, etc. So we may say that this is likely to be hereditary. Whether it will repeat or no, we cannot say. But if it is not very essential, you may avoid having a second baby because it's if it repeats, then it's not good for you. And that's the counseling that is to be done because there's no prenatal diagnosis available. And mostly the parents would take a hint.
One normal child. So tell them that don't take a chance. We could possibly antenatal diagnose. That also we are not sure. Even if we diagnose, we will not be able to prevent further damage. You have one normal child, you will have to spend a lot of time, money, energy with this child. So it is best I advise you not to have any more children. That would be the right advice.
You learn many good things here. But one of the best things that you learn here is counseling. So ensure that you ask for counseling if we forget. Because it has a lot of weightage in the exam and in the life. Most of us fail in that.
Eight-year-old male child, third by birth order, born out of non-consanguineous marriage, resident of Govandi, hailing from Bihar, Muslim by religion, Sheikh by community, brought by mother with complaints of fever for 2 weeks and pain abdomen for 4 days.
Quick assessment of what they understand. So when somebody starts talking, fever for 2 weeks and pain in abdomen for 4.
We cannot hear anyone.
Can you hear me now?
Yes.
Yeah. So, so what kind of fever do you think this is, which is without any other symptoms? Viral is most unlikely. Bacterial is less likely because it could have totally localized with some symptoms. So you don't have acute or viral or bacterial. Could it be a low-grade bacterial like tubercle? Maybe. We are not sure. Okay. Could it be a parasitic disease like malaria? Less likely. Okay. Because it could have been up and down, whatever. Okay. And would have either got worse, got better by itself. So then we have possibly a low-grade bacterial infection like TB, but nothing else. Or could it be non-infective fever itself? Okay, there you will like to know low grade, what's the pattern, etc. Yeah. So even without knowing that, we have tuberculosis as one and a non-infective inflammatory disorder as another. Now that fellow gets pain in abdomen. Now join the two. Could it be abdominal tuberculosis? You had a TB as one possibility, and now abdominal. So abdominal tuberculosis.
Enteric fever can be possible.
Enteric fever is a possibility. Yes. But pain in abdomen is not a very severe symptomatology. It doesn't come up after 8 days. But yes, it's a gastrointestinal infection. Okay. Fair enough. Fair enough. But more than pain in abdomen, it could be a vague symptoms like distension, change in bowel pattern. But you have given a good thought to rule out to typhoid fever. Very good.
Perforation can occur at
Fine. But then it would not have been for 4 days pain in abdomen, right? So to me, intestinal TB, no? Or then inflammatory bowel disease, autoimmune fever, inflammatory bowel, and TB, abdominal TB. Join the two symptoms. How do you like that? Anything against?
Abdominal symptoms come first in inflammatory bowel than fever.
So you would have said abdominal TB does not have fever for 10 days and then pain in abdomen. Abdominal TB is rarely acute, but could have a repeated episodes of intestinal obstruction like a subacute intestinal obstruction. But this is not that. Other abdominal tuberculosis are often without fever or just chronic going on and on with abdominal symptoms predominating than fever. So this is not tuberculosis. Okay. What about inflammatory bowel fever and abdominal pain?
She said that the local symptom should have been first in inflammatory bowel.
You're right. And fever alone is little unusual. So we are not fitting it in any way. Okay. Therefore, we go back to what she said. Could it be still typhoid?
Now, does treatment alter their interpretations? So suppose this child has been haphazardly treated with antibiotics outside, then what would happen? What could it be? Could it be a partially treated bacterial? So initially, as sir said, we ruled out bacterial, but then we were assuming it is a pure case, which is, which should have localized by now. But when get treatment, the things can get modified.
We keep all this option. Now show us the next slide. Don't show too many things. We can add on our interpretation.
Child was apparently all right. 14 days back. Then he developed fever. Fever was moderate to high grade, intermittent, undocumented, associated with chills, 1 to 2 spikes per day, child active in interfebrile period. Pain in abdomen, dull aching, insidious, no history of radiation to any other site, no aggravating or relieving factors.
So now you got some more about type of fever. Now tell me, typhoid, TB, autoimmune, malignancy, what all things are you now doing? Now you have to narrow it down. 1 to 2 spikes per day, active interfebrile. Typhoid is out. Okay. High fever. In TB, high fever is an immunological fever. Generally pleural effusion, pericardial, okay, meningitis, but all that is out. So TB is out, typhoid is out. Okay. So likely it's a non-infective inflammation. Okay. But non-infective inflammation, we don't have the chronology that she talked about. So again, could it be malignancy then? After all, abnormal symptoms have come later. So what have you to consider malignancy? Okay, leave that for a while. Tell me, what is the pain in abdomen coming from?
What is the most important thing which is missing in that pain in abdomen? Sight. So where is the pain?
Diffuse in nature. There was
All over the abdomen.
Generalized pain. Okay. Dull ache.
What does that say?
What is dull ache means what? How can the pain be dull?
Distension of an organ.
Distension of an organ, but
No, of an organ.
yeah. So distended organ. Okay. So in other words, he's trying to say that the dull ache is really related to some organ and not peritoneum. Okay. So we got that clearly. What organ? Then he said enlarging organ. So capsulated organ where the capsule is empty. So we could have also said how severe it is the pain.
Exactly. Next question is it just mentioned or is it severe? That makes a lot of difference.
It was not very severe.
Not very severe.
Not very severe. Okay. So it could have been what you said. Okay. That some organ is being stretched slowly, insidiously, then that's why pain. But it's not certainly hepatitis, okay, pancreatitis, okay, all that is gone, nor any peritoneal affection. So now, what must be? Autoimmune is not there. Can it be a malignancy now? Stretched organ. So which organs have a capsule which is stretched? Liver is one. So could it be a hepatomegaly with fever for 10 days? Okay, which other organs? Spleen. Okay, and which third organ in the abdomen?
Kidney.
Huh? No, with a capsule which will get stretched.
Lymph nodes. So is it a lymph node pain? Now, which of these have fever? Malignant liver? Hepatoblastoma has fever? No. Unusual malignancy, age, etc. So it must not be. Could have a large spleen have fever? Malaria? Kala Azar? Disseminated tuberculosis? But all that we said doesn't look like. So could it be a lymph node? Okay. And if it's a lymph node, tubercle or Hodgkin's? So more likely Hodgkin's. Just an imagination. Okay. I think the fun sometimes is to imagine something. Okay. It's like a dream. And unless you dream, then you cannot progress in life. You have to dream to say, after a year, I'll be MD pediatric. Then I want to do super specialty. Then I will be a big consultant. Then I will start my practice. But many corporate hospitals will invite me because I will have the dream, right? Then only you can pursue. Let's see what happens.
Go ahead.
There was no
Nothing
complaint.
important.
Go ahead. Skip
Go
this.
further.
Past history. Child initially presented with complaints of high-grade fever since 3 days in February 24, received treatment on OPD basis, symptomatic meaning. Later, child again presented with similar complaints in July 2024. Fever, pain, abdomen, and generalized body ache was present. Shown to a local practitioner and was started on steroids for 20 days, leading to some symptomatic relief. Patient later went to KM Hospital in August 2024, presenting with similar complaints, advised to send some blood tests and follow up in OPD basis. He was given some medications and treated on OPD basis here.
Skip all this. Okay, fine. We'll examine the child. लेके आइए बच्चे को.
So now, so far, what's the probable diagnosis? They give some past history. Somebody gave steroid. It must be inflammatory disorder. What do you think? Autoinflammatory disorder? Come, let's examine the side. Come near. Now, who wants to talk now? Last time he talked. Okay. Somebody else wanting to.
Findings are right. What about abdomen? I think is normal rate, sir. And
Do you think it's distended?
no.
So it's not distended as in his sleeping position, the plane of the abdominal wall is not above the chest. But at the same time, in a child of this age, you normally expect a little concavity, a little scaphoid. So that scaphoid is missing, right?
Down to that level, and if you see that, then the left hypochondrium and left side looks a little more prominent. We're not going to just go by that. We'll palpate as much. But the impression is that there is an abdominal distension more in the upper part, certainly not on the flanks, not in the lower part, and little more on the left side than on the right side. That is the observation, right? Where is the umbilicus placed? Umbilicus placed in the middle of the abdomen, or it is little on the downside. Look from here and look from here. Umbilicus is pushed down. Umbilicus is pushed down. That means upper abdomen, there is some space occupying lesion. So again, spleen plus liver minus liver, whatever. We got that, right? Obviously, there is no other venous congestion. There is no ascites. So it's not a portal hypertension. Yes? Now come and palpate. And now it also said there is no jaundice. There is no significant pallor, because now we are talking about clean liver plus minus. So no pallor, no jaundice, right? talking and give a running commentary so that we know what it is. No, come on, come on. Gula. Gula. That's one.
We cannot hear anything.
Ma'am, I was about to say that only. Sir, you are not audible.
Khare sir, we can't hear you.
Sir, can you check your speaker, please? We cannot hear you.
The mic is not on.
Can you check, sir, once? Kindly check your mic, sir.
Hello.
Yes, yes. You are audible now.
It gave an impression of a little distended abdomen, but you have no liver and spleen, but still little distended. So then the question is it doughy abdomen? So what is doughy?
When on dipping the fingers, don't go easily down. There is some resistive feel felt while palpating.
Doughy abdomen offers a mild resistance to palpation. You look at the dough, okay, mild resistance.
Sir, abdomen, though doughy, I can go and feel the spine.
Doughy
But
abdomen.
on this side, I get a little resistance, left iliac fossa. But right side, I did not get any particular resistance. Right here also, I was able to. So I thought his colon is a little loaded. And that is why, but I didn't give much importance to that. I'll just ask for a history of constipation. And otherwise, I would pass this abdomen as relatively normal.
So constipation is another cause to rule out, which might look like doughy. Sometimes the round worms can grow that, and therefore this probably is that. But even now, I feel there is a little distended abdomen, and I need to be very sure on investigation. Right? Okay.
Abdomen is going up and down, up and down. I counted 3 times. Once it came to 28, once it came to 32. So close to 30, which is tachypnea by all means for this child. Can it be a referred pain from the chest to the abdomen?
Pain is all over. So referred pain is a localized pain. This is all over the pain. So definitely all over the pain has to be intestinal, peritoneal, or a lymph node. One of the three. The rest are all quadrant pains, liver, spleen, this, that. So this is unlikely a peritoneum unless we are talking about a plastic peritoneum like tubercle. Okay. Lymph node, we are not able to palpate any mass, but suppose there is a small lymph node coming up there, we won't know that. Okay. And it's unlikely an intestinal problem because there is no significant change in the bowel pattern. Okay. And therefore, we still look at a general abdominal pain as a peritoneal pain or a gaseous distension, which could be subacute obstruction of TB itself, or it could be really a lymph node. So we'll investigate those, right? So quickly tell us now what has been done and what are your findings.
Vitals on examination, child was afebrile, active heart rate
Tell
of
us positive finding.
child was vitally normal. BP was between 58 to 98 center.
All normal. Go ahead.
Hypopigmented macules present over
Go
face.
further. Go further.
Anthropometrically, child was normal.
Normal.
On per abdomen inspection, normal shape, no dilated veins, scar, centrally placed umbilicus, no guarding, no tenderness, no rigidity, no signs of organomegaly. On percussion, there was no shifting dullness, vowel sounds present, 2 to 3 per minute. Respiratory system, air entry bilaterally equal, no adventitious breath sound. CVS S1, S2 present, no murmur. CNS, tone, power, and reflexive normal. Everything was normal.
So quickly, somebody to say what investigation would you be doing? Don't say LFT, RFT, electrolyte, acid base. That is common for all. Okay. I think when you register at the window outside to take the paper out, at that time only they do all these tests and say paper के साथ सब report लेके जाओ अंदर. So what test will you do? Though I felt that abdomen was not looking very normal, but suspicious. But there is nothing positive. Now there is a disease, all right, and disease must be in the abdomen also. So what investigation? Come on, not difficult.
CBC, CRP,
CBC, CRP, then
blood culture,
blood culture, then
factor, but because of PO, we'll like to do with
Okay.
blood culture. And
ultrasound abdomen. And what is a screening test for tuberculosis?
Chest X.
chest X.
Chest X-ray.
We have sent the CBC of the patient. Initially, hemoglobin was 9.1 gram, hematocrit of 26.9, total WBC count of 30,000, platelets of 6,52,000. There was neutrophil predominance in the WBC count.
It's only. Okay, go on.
And then
Next one, next investigation.
OLD was sent, which came out to be negative. We sent peripheral smear, which was polypredominant. Eosinophils were present. There were no abnormal blasts. Retic was 0.2%. ESR was 118 mm per hour. Thyroid profile was sent, which was normal. Urine RM sent, which was normal. Blood culture was sent, suggestive of Acinetobacter species. Since
It's an allergic disorder. Eosinophils are predominant. And allergy is immune, no? So it's an autoimmune disorder. But if platelets were also a bit high, so autoimmune, mild, moderate anemia, autoimmune.
Fox worker Cox workup was sent, GLG was negative, chest X-ray was normal, ICP negative, USG neck was done, suggestive of enlarged bilateral cervical and inguinal lymph nodes. Cervical lymph node, US.
Axillary are also bilateral. All are discrete, non-tender.
USG AA plus P was done, suggestive of mild hepatomegaly. CRP was sent, value 228.6. Chest X-ray was normal. These were previous investigations which were sent last year. So
Anything significant except low hemoglobin?
So child has persistently high counts. In 6th Feb, the counts were 18,900. CRP was 76.6. Then again, the CBC sent, the counts were 24,500. Urine RM was sent, occult blood was.
What is the differential?
UTI can be.
No, differential of CBC of the high count.
Neutral predominant. Every time it was neutral predominant.
And hemoglobin is falling down consistently, 9.5. Three hemoglobins which you said, they're progressively going down.
Urine RM was sent, occult blood was 3 plus, bacteria present, RBCs 30 to 35 per high power pill, pulses 3 to 4, FTS at 2 to 3.
This was 1 year back.
1 year back.
Forget that.
Sir, we also did LP of this child. It was acellular, proteins and sugar of 53. CT brain was done, that was also NAD.
Okay.
So right now we have not got some focus for the P.
How is he still running fever in the ward?
1 to 2 fever spikes were present, but
how high? How high?
Tmax was 38, sometimes 39 this way. So after giving blood culture sensitive antibiotics, the patient was the fever spikes reduced.
And appetite and weight?
Child has good appetite. He eats.
The acute phase reactants are very high and abnormal. So it has to be a progressively inflammatory infective disease. And here we have no clue whatsoever. So the only clue is possibly there is something hiding in the abdomen, whether it's in the intestine itself or it's only in the lymph node. And there are peripheral lymph nodes. Now, at this age, to have peripheral discrete lymph nodes is also not usual, though of course if somebody is unhygienic, he can have lymph nodes everywhere. Okay, or is very thin, but that was not so. So possibly we need to further look at this, whether we are still considering a lymph node disorder, unlikely an intestinal disorder, unlikely a peritoneal disorder. Okay, but a plastic peritonitis would still do the same. And I think we will have to further investigate this child. Anything else you have done so far?
Sir, actually, child was outside labeled as JIA, juvenile idiopathic arthritis. So he was given steroids for 20 days. I asked for the history of joint pain, but the patient said that he does not have any joint pain.
This is unlikely a classical rheumatological disorder. We are between a chronic infection or a malignancy. And infection is tubercle and the malignancy is the lymph node. So now we will have to look at a 3-digit ESR is exactly what TB or malignancy has. We can't go by 2 or 3 digits, but 3-digit ESR is a very significantly enlarged thing.
I think because of the rising blood count and high polys, whether they were thinking of collagen vascular disease, something like Kawasaki, but it's too good for a Kawasaki.
Yes, so what will you do next? So one option is one of the lymph node biopsies, whichever lymph node is accessible.
But meanwhile, ceftriaxone.
Sir, they are giving as per the
as per blood culture.
That blood
64.
culture grew Acinetobacter, so they are treating that.
That fellow must be laughing at us. He says, I fooled you.
How severe is the
Yeah.
abdominal pain?
So it was not severe. It is very mild to moderate grade, the leaking.
No, we are not going to treat that positive bacteriological examination. No. Clinically, nothing of that kind. And where is the disease? We know what the disease is. That means we know the name of the thief. But has he done anything? No, I don't know. But I know the name. So infection is out. That bacteriological culture is possibly not the answer. Of course, you will give treatment to confirm that either the drug is not working or the report is wrong. I will not accept you to say the report is wrong. So you'll have to upgrade the antibiotic. If this antibiotic doesn't work, so you will be more of a problem. Don't forget 10 days of infection. What has happened to this child so far? Where is it localizing? Nowhere. And a very dull abdominal localization, not very specific. It's not an infection of any kind. Right? Anyway, I think please tell us the follow-up of this also.
Next Thursday, let us know what turned out. Okay.
Possible to get community acquired also.
That's what we are saying. No, we are not ready to accept that this is just Acinetobacter infection, which is SI just 2 spikes a day and in otherwise normal child and from the community. Doesn't look like that. Chalo.
Thank you
Okay,
very much.
thank you. Thank you.
These are simple loudspeakers. Personal. Put it here and your voice comes loud. There are two sets. So students can use it or one more teacher can use it.
And everyone who participated.